our goal for the meeting today or training today is to share the best practice for all everywhere in the world. Good morning, good evening, or good afternoon for people in Tanzania. Good morning, people in America and everywhere in the world. We are so excited. This is our first session for eclamptic obstetric emergencies, and we are so excited to have this training ready. Usually the training takes an hour, and we have usually the 5 minutes to invite people, and then we let the presenters start presenting. So today we have our sister Dolores. I'm going to give her a few seconds to introduce herself, and then we have Dr. Paula, and then also Dr. Emma. So invite you, introduce yourself, please.
Good morning, everyone. My name is Dolores Goodmartin, and I'm a nurse at HCA Palms West in Florida. I have been a nurse since 1998, but work as a labor and delivery nurse since 2004. My experience started in Jamaica, and then I transitioned here to the US in 2015. So that's a little bit about me.
Thank you very much. We cannot wait to hear all the great experience you have, very rich experience. Dr. Paul?
Thank you. Good afternoon in Tanzania and good morning from US. I'm Dr. Miriam Elias Paulo, a medical doctor. Currently, I'm working at Mwananyamala Regional Referral Hospital as a registrar in Department of Obstetric and Gynecology. So I'm proud to be part here, learning and share experience. Thank you.
Thank you very much, Dr. Miriam. We are so excited. We've been to Mwananyamala a number of times, so we are so excited to have their collaboration in this training, because without you guys in Tanzania, we can discuss what we know here and we might not be able to learn from you guys. So I'm glad you're here to give us the background and the scenario. So Dr. Paula is going to be able to present to us the scenario going through the training.
So good morning, everybody. It's great to be here again and to discuss about eclampsia. So looking forward to this discussion.
Yes, and we are blessed to have Dr. Emma for a long time now. We always try to hijack her to come and help us with this presentation. And I'm glad she's able to come and do it today. We are so honored. As I said, we have our 3 esteemed people here presenting today.
Maybe the only other thing I can add is I am an obstetrics and gynecology doctor. I work in Greensboro, which is a city in North Carolina. And I see all types of patients. We have a lot of low risk patients, uncomplicated pregnant patients, but also we do get some high risk patients. So people with preeclampsia, eclampsia, diabetes. So it's a pretty busy practice. And I deliver out of Moses Cone Hospital, which is in Greensboro here in North Carolina. And I am a fellow of American College of Obstetrics and Gynecology. So that's how I keep up with what's up to date and what's new. And I love what I do, and I'm very excited to be involved with Dr. Harriet Gabon with her project. So I'm looking forward to this session.
Thank you very much. Yes, definitely we are excited and ready to start the presentation. Today we're going to cover the pathophysiology of preeclampsia, recognized causes, clinical features, complication and management, and then differentiate preeclampsia versus eclampsia and application of eclampsia management through the scenario. So the 3 of the presenters will be able to start sharing. And then now, Dr. Emma.
So when we think about eclampsia, basically it is new onset generalized tonic-clonic seizures, or also could be a coma, in a patient who has gestational hypertension or preeclampsia. So basically, eclampsia is related to pregnancy. And so if a woman has elevated blood pressures, which can make you make a diagnosis of gestational hypertension, or they have preeclampsia, or they have other things like HELP, which are all pregnancy related and all also cause elevated blood pressures. And then on top of that, they now have seizures, then that's what we call eclampsia. A lot of times the seizures are tonic-clonic, basically meaning that there is some tightening of the muscles and then maybe some like twitching of the muscles. And a lot of times it's the whole body that's involved. But sometimes there are some atypical seizures which could involve maybe one part of the body. So those are what we call the focal seizures, but most of the eclampsia seizures involve the whole body. So the precise cause of eclampsia is not really known. However, we do know that at the bottom line, the brain is not functioning normally. And so one of the theories is that maybe because of the high blood pressures, there is too much perfusion of blood in the brain, which kind of causes some changes in how the brain regulates itself. And then that may cause injury to some of the brain cells, which can then trigger the eclampsia. However, the other model says that because of the high blood pressure, then the brain may over-regulate itself, and this may actually cause now constriction of the blood vessels and lack of good blood flow to the brain cells, which can then trigger the seizures. But the bottom line, high blood pressure seems to play a role in its origins. Next slide, please.
Yes.
Yes, and now let's talk about preeclampsia versus eclampsia. Like I said, preeclampsia usually is the initial presenting part before eclampsia happens. And so a lot of times the patients will come in and maybe they have the high blood pressure and maybe you do some tests on them and you see some laboratory abnormalities that convince you that they have preeclampsia. Or they may have some symptoms which make you think that they do have preeclampsia. And then maybe along the course of their presentation, they do develop the seizures. So usually that's the usual presentation. But sometimes you might have a patient that just presents with a seizure from the get-go. Maybe a patient who, for example, hasn't really been getting prenatal care and shows up at the hospital after a seizure, and then even before you've taken any vitals or done any blood work, that's like the initial presenting symptom. But some patients, like I said, may have high blood pressure. They may have symptoms like a headache. They may have changes in their vision. Some of them describe they see like spots in the eyes. Maybe they cannot see very well. Like they have like half vision, maybe even. They may have some pain issues. A lot of times it's the right upper quadrant pain where the liver is, because the liver can also get affected in preeclampsia. Some of them may have epigastric pain, and some of them do not have any symptoms at all other than the seizure by itself. If you were to examine the patient, you may notice that their reflexes are very strong. So, we talk about like mild reflexes, like 1+, but a lot of times these patients have like, 2+ reflex or 3+. You hit their knee area and the knee is jerking very quickly. And maybe if you're to test and ask them, can you see over here? They may tell you, I can't see over here, or you see over here, I cannot see. So there could be some changes in the vision. How does the seizure usually appear? Like I said, it's usually the whole body experience. But you may notice that the patient loses consciousness initially. Maybe they were talking and then all of a sudden they're not talking anymore. And then they have this like stiffening of the muscles of the arms, the leg, the chest, the back. Um, and this may last for about like a minute where they're just very, very stiff all over. And then the muscle will start like jerking and twitching, maybe for about like a minute or two. Sometimes they may bite their tongue. Sometimes they may have this frothy or bloody sputum that comes out of their mouth. And then this may go on for just a few minutes and then it resolves by itself. And like I said, some people may just have like one part of the body that's maybe like jerking, like a hand or a leg. And then some of them are just completely unresponsive and they have slipped into a coma. After they are in that state for a few minutes, then usually they will appear to be like resting for a little bit, maybe sleeping, breathing deeply, and that's after the muscles have stopped jerking. And then they will gradually like wake up, and maybe sometimes they'll complain that they feel a headache. And then over time, they become more aroused and fully awake and back to their normal selves. And this could take about 10 to 20 minutes. And usually when they wake up, they are completely back to themselves. They do not have any deficits. Like, for example, they are able to have full function of their arms and legs. If somebody has what appeared to be a seizure, and then they come out of it, and now, for example, they cannot like use their arm or use their leg, it probably wasn't eclampsia. Maybe that was something different. Things like strokes could also seem like seizures. But with eclampsia, the patient is back to their baseline with full motor and sensory function. When a patient is having the eclampsia, because they are going through the motions of the muscles jerking and twitching, they may not be breathing as usual. Therefore, oxygenation of the baby might be affected. And usually the baby responds by having a drop in their heartbeat. So the heartbeat of the baby may drop to below 110 beats per minute. And this may stay there for about 3 to 5 minutes. And of course, this entire time, the mom is having all those seizures. And then usually once mother has finished the seizures, then the baby will actually now become a little bit tachycardic. Now the baby is recovering from all that, and the heartbeat may be a little bit elevated, more than 160 beats per minute. And you may notice that there is a loss of variability, and maybe the baby may have some deceleration. So these decelerations could be variable decelerations or early or late decelerations, but basically the baby is recovering from all that. But usually by 10 to 15 minutes after the seizure, the baby is completely back to its baseline heartbeat. Therefore, a lot of times, even if you see that the baby has a low heartbeat or a super high, you just continue to focus on resuscitating the mom, because we do know that a lot of times the baby's heartbeat will go back to normal. However, if in 10 to 15 minutes after the seizure, baby is still having an abnormal pattern, then you have to worry that maybe the whole seizure caused other complications such as placenta abruption, and that in that case, you may need to deliver the baby quickly, sooner rather than later, because the baby is still under a lot of stress. Next slide, please. All right, so let's talk about treatment of eclampsia. So it goes back to just focusing on the mother and ensuring that her airway is open, that she's able to breathe. You may want to give her some oxygen. It's always advised to roll her to her left side, because being on the left side is good for blood perfusion to the placenta, ensuring that the baby's getting a lot of oxygen as much as possible. But also when you're on the left side, there's less risk of some of the stomach, the stomach contents moving up into the esophagus, which can then increase the risk of things like aspiration. So the left side is the best position. If the mom is in bed that has these rails on the side, you probably want to raise up the rails so that they don't fall off the bed and injure themselves. You also want to assess her vital signs. If, for example, she's having high blood pressure, you always want to give her something to help with the blood pressure. So things like intravenous labetalol or hydralazine, because we all know that uncontrolled high blood pressure in pregnancy can also lead to other complications such as strokes and heart attacks. Definitely, you want to give them some anti-seizure medication at that point, maybe after the seizure has broken. And so you want to consider giving them magnesium sulfate, which, hopefully if the patient came in and you made a diagnosis of, for example, preeclampsia with severe features, the patient could already be on it. So you may want to continue with the magnesium sulfate if they're already on it. But if they're not on it, then you could go ahead and start it at that point. If the patient, however, is continuing to seize, like let's say 5 minutes later, despite the magnesium sulfate, then you may want to consider other options like lorazepam. Uh, they recommend like 4 milligrams IV, which you could repeat again in 3 to 5 minutes. If there's no IV access, you may want to give them midazolam IM. So those are the other options you could do. And it's very interesting to note that about 10% of patients who have eclampsia will actually have repeated seizures. And therefore, that's why it's important to continue, for example, the magnesium sulfate if they're already on it. You don't want them to keep getting repeated seizures because that can affect their oxygenation, their respirations, and it can affect the whole body, because if mom is not getting enough oxygen, the brain is affected, the muscles are affected, and of course, there's always the risk of aspiration, where the stomach contents are now finding their way into the lungs, which obviously is not safe, will affect how the mom is breathing, can cause infection in the lungs. Therefore, what is recommended to prevent recurrent seizures is you could give them a magnesium sulfate load, maybe 4 to 6 grams load, and then you can continue 1 to 2 grams an hour. And you could continue that for about 24 hours because the risk of recurrent seizures is greatest in the first 24 hours after delivery. I think I forgot to say that for 24 hours after delivery. And you could potentially continue it for beyond even 24 hours, especially if it looks like the mom is not maybe recovering from the whole preeclampsia and eclampsia, like if the blood pressures are still not well controlled, if maybe you do some blood work and they are not resolving some of the like liver function, then you may want to continue the magnesium sulfate for even up to 48 hours after delivery. If you don't have IV access, you could give them intramuscular magnesium sulfate. So you could give them like a 5 gram load on each buttock, and then you can continue 5 grams IM every 4 hours. And this one, of course, it can be a little bit painful. So they always recommend that you mix it with a little bit of lidocaine so that it's not so uncomfortable for the mother. And the studies show that magnesium sulfate is more effective than diazepam, phenytoin, or other cocktails of anti-seizure medication, and specifically to prevent the reoccurrence of the seizures. So magnesium sulfate is the way to go if possible. And apparently it's also cheaper than the other options, and it's available in most places. Next slide, please. Okay, so what if you have a situation where you are giving the magnesium sulfate and the mother is still having continued seizures, recurrent seizures? Then at that point, you may want to obtain the magnesium level because maybe she's not in the therapeutic range. Maybe she needs to get more magnesium, more magnesium sulfate. But also, what if you get the level and you see that the level is very high, then you may not want to keep giving the magnesium sulfate. You may want to hold off on giving her another bolus again, and then maybe increasing the rate. So that is the case where you may want to opt for other anti-seizure medication, especially if her magnesium level is above the therapeutic threshold. If they're having more than 2 recurrences despite all these measures, then yes, you can consider other options like fosphenytoin, IV or phenytoin. And that might also be a good time to involve the specialists on seizures. So maybe a neurologist to come in and help and recommend what else you could give, depending on what's also available at your hospital. There's one particular medication called valproate, which I do believe they do not recommend to ever use with pregnant women, because it does have a high risk of causing malformations in the baby, but also they say it can affect neurodevelopment of the baby even after it's born. So it's recommended to avoid valproate, but it looks like the other options like phenytoin are okay to consider. And like I said also before, if the baby's heartbeat hasn't recovered 15 minutes after the seizure despite resuscitation, then you want to consider doing an emergency delivery, maybe a cesarean section, especially if they are remote from delivery and you need to deliver the baby sooner rather than later. If somebody has eclampsia, it's pretty clear that they should be delivered, because delivering the baby also will help to prevent further reoccurrences of the seizures. So once the mother is stable, you want to now decide, okay, should we like induce the mother so that she can have the baby, or should we proceed with a cesarean delivery to decrease her risk of, this eclampsia persisting? So you definitely want to proceed with delivery. Next slide, please. Oh, yes. And I did get a lot of my information from a website called uptodate.com. This is a website that does like research. They will pull all the articles that have been talked about the topic, and then they will summarize it for you. So it's a very good resource, uptodate.com. Thank you.
Very much. Yeah, thank you very much, Dr. Emma, for the presentation. And we're gonna welcome now Miss Dr. Malaria. Dr. Paul?
Thank you, Dr. Gabon. Hello.
Hi.
Thank you. So I'm going to take you through the scenario. We had a patient on how we manage on eclampsia. So by starting with the introduction of the patient scenario, she was a referral case from a near health facility with the diagnosis of pregnant-induced hypertension. There she was given tab methyldopa 500 milligram and tab nifedipine 20 milligram. Then she was given referral to our facility. However, due to family issues, the patient delayed to reach to our facility. So she went home thereafter.
Oh my gosh.
So her name with the initials FMH, 19 years old, female, prime gravida at gestation age of 32 weeks by ultrasound. She presented with chief complaint of lower abdominal pain for 1 day, headache for 1 day, and convulsions at home for 1 day. So she had headache, more on frontal head, throbbing in nature, not relieved with pain, not associated with blood vision. She also reported intermittent cramping, lower abdominal pain, radiating to the lower back with PV mucoid blood discharge. She also reported to perceive fetal kicks. The next slide. The next slide, please.
You should be showing the presentation.
Okay.
On
On arrival, On arrival, during examination, patient had generalized tonic-clonic conversions, lasted for about 1 minute, associated with eye rolling and tongue bite, with history of 1 episode of conversions at home before arrival on our facility. No history of epilepsy. She had inadequate antenatal clinic contacts where she had only 1 contact. That was at gestation age of 21 weeks and 3 days. During that visit, her blood pressure was 133/84. MRDT was tested negative. She was PMTCT2, and she was given malaria prophylaxis. However, during these antenatal contacts, most of investigations were not performed, as the patient started to attend her antenatal clinic visits while she was in the countryside. So on her past medical history, no history of any chronic illness like diabetes, hypertension, and no history of seizures, and no history of head trauma. So on general examination, the patient had post-ictal confusion. She was febrile, not pale, not jaundiced, not dyspneic, no lower limb edema. Her vitals, blood pressure was 154/101. Her pulse rate was 124. Respiratory rate was 20, and she was saturating 98% on room air. On systemic examination, on central nervous system, Glasgow Coma score was 14/15, and RBG was 3.8. On a cardiovascular system, S1 and S2 had no added sounds. On respiratory system, she had vesicular breath sounds, and per abdomen, she had gravid abdomen with fundal height of 30 centimeter. Fetal heart rate were not heard, and she had mild contractions with longitudinal eye and cephalic presentation, and descent of 4/5. On per vaginal examination, her cervix was 2 centimeter, soft, thin, posterior with intact membrane. So from there, we had diagnosis of eclampsia at gestation age of 32 weeks in labor, and together with HELP syndrome.
Thank you, Dr. Miriam. So before we go to what happened to that patient, and remember, as we are discussing right now, we are all learning. So things that were done routinely, things that could have been done is through the discussion, and that's how we learn. And then even if the best practice, sometimes the outcome might not be the same, or even if people did everything by the book, like for the guidelines, for the protocols, for the order set, being prompted to the care of the patient, the outcome can still be different. So as we're discussing today, this case, we are trying to share best practice from Tanzania, US, and in Jamaica to try and figure out what is could be done in the future, and then so we learn from that part. So starting with that discussion, we have our sister Dolores. This is a nurse from US and has experience from being a nurse in Jamaica. She's going to share her routine care if she received that patient to where as a nurse, what she should do as a nurse, what are the things that she should be preparing, and what is the expectation, what are the core for the doctors to support the care of that patient. So Sister Dolores, please.
Good morning, everyone.
Good morning.
So as mentioned before, my name is Dolores Good-Martin, and I'm a nurse at Palms West Labor and Delivery Unit in Florida. So when a patient with eclampsia presents to our unit, the first thing we are looking at, just like with any resuscitation measure, you're looking at your ABC, your airway, breathing, circulation. So how is this patient presenting to you? You want to establish that level of consciousness. Is this patient perfusing okay? Even though she's pregnant, we are focusing on the mom initially, to make sure that mom is okay. So when this patient presents to our triage unit, first we connect them to the monitor because we want to monitor the blood pressure. We want to monitor the oxygen level. We try to get large bore IV access in. preferable a 18 gauge IV access. If we can't, we try a 20 gauge, but not less than a 20 gauge and at least 2 access, because in this case you are thinking, and for example, in this scenario, mom had HELLP syndrome. HELLP syndrome is where the mom red blood cell is breaking down, the liver enzymes, they are elevated, and she has a low platelet level. As a nurse, your antenna goes off, you're anticipating that this patient is at risk for bleeding. So you want to have 2 IV access in, so you can, if there's a need for blood transfusion, you can transfuse your patient. Also, the blood pressure in this scenario is elevated. And in an eclamptic patient, the fastest route is always through the IV access. So you want to have an IV access when this patient comes to you. So in the US, we use labetalol a lot. So the labetalol protocol is what will be anticipated. Of course, when this patient comes, you would have already alert everyone that you have this patient, an eclamptic patient. We have this alert that we use. It's called an OB alert. If this patient is in a room, then we have, and this happened, the patient having an eclamptic seizure, then we would press our button that would call for staff assist. It says staff emergency. And so we use that. So the first thing is to get help. So you want every hand on board. Then you connect your patients to your monitor to monitor your baby, to monitor your vitals, to monitor your oxygen level, as was mentioned. But as was mentioned in the presentation by Dr. Emma, during the seizure, the baby heart rate will go down. So at this point, we are not really focusing so much on the baby heart rate. We are trying to stabilize mom. Because once you stabilize mom, then baby will be stabilized. So the main focus will be on getting the mom stable. And as we mentioned with the labetalol protocol, we use the labetalol protocol a lot in the US. That is where we give 20 milligrams of IV labetalol. We monitor the blood pressure, take another blood pressure in 20 minutes. If that blood pressure is still high, then we go to 40. We monitor again. If it's still high, we go to 80. If that doesn't work, then we move to the ijalazine or apresilin, where we start with 5 milligrams, and then over 10 minutes, then we move. If still high, then we go to 20 milligrams. If that don't work, then we move to Procardia. Very rare we have to go to Procardia or nifedipine, because the name is different in Jamaica, or maybe in Tanzania, they use nifedipine. In the US, they use Procardia. But very rare we have to go to that. The apresilin or ijalazine tends to work when we go to that. Also, this patient has eclampsia. Of course, magnesium is going to be ordered. We are going to start our magnesium bolus. It's normally on a pump. We try to give that 4 to 6 gram bolus, depends on the provider preference, over a 20 to 30 minutes period. Most time it's 20 minutes, because you want to get that bolus in 20 minutes or 30 minutes the most. Then again, pertaining to the doctor's preference, it may be a 2 gram maintenance dose every hour, and that you will find, because we are using a pump in the US, it's our magnesium is 20 grams in a 500 milliliter bag of sterile water. So that 2 gram will be running on the pump at 50 milliliters an hour. In Jamaica, however, where I started, we didn't have this luxury. So it's the IM route we go to. That patient get that maintenance dose via injectable. So the part of the loading dose, you give 2 grams IV, and then 10 grams IM, 5 grams in each buttocks. And as Dr. mentioned, every 4 hours, then you will be giving that 5 gram. in the muscles. However, what we find happened when I was in Jamaica, a lot of patients, because it's so much you're giving into that buttocks, they end up with like abscess to the side. And, so before I left Jamaica, one of the things that they were experimenting with was instead of giving it IM, they were trying to use Biratrals to give that maintenance dose. But as a nurse, you have to make sure that you are monitoring that Biratral very closely. The Biratral you will find used in the pediatric department to give medication. So they would put that 100 milliliters in that Biratral, and so you have that continuous infusion going. But as I said, you have to monitor closely because sometimes the IV is positional and you come back and it's run out. So you have to make sure. So we try to make it be a one-on-one. That patient is a one-on-one to nurse. So one nurse is monitoring that patient. However, in the US, you may not find it in the acute phase is one-on-one. You may not find it once the patient is stable. You might have another patient, but at least two. You won't go beyond two with a patient like that. But in the acute phase, it's one-on-one. So once this patient in the acute phase, you're monitoring this patient one-on-one. And as I said, we'll be monitoring the patient urine output. This patient will have a Foley catheter in. Once they're on magnesium, we put a Foley catheter in because we want to monitor the urine output. This patient should be putting out at least 30 milliliters of urine every hour. We want to monitor the respiration, and we monitor, once this patient is on magnesium, it's hourly monitoring. When we start that bolus dose, the vital signs monitor is programmed to go off every 5 minutes for the first 4. So you do 5 minutes times 4, then 15 minutes times 4, then 30 minutes times 2. Then once everything is stable, we go to hourly. But that's the standard of practice in the US. In Jamaica, it's totally different. So we want to send blood work. We're looking at the complete blood work, which is the main labs that we are looking at here in your complete blood count is your hematocrit, your hemoglobin, and your platelets. Then we do the complete metabolic panel. We are looking in that the main things we are looking at is your creatinine level. We are looking at the liver function, your AST and ALT. Those are the main things we are looking for in the complete metabolic panel. In the past, we do uric acid. We still do, but the main we focus now. Things change. Is the creatinine level? Is my creatinine over 1? And if it's over 1, that's telling me yes, this patient is definitely preeclamptic, eclamptic, even though we have all those signs. But also your ALT and AST, your platelet, is what will tell you if this patient is in HELLP syndrome. Also, we will send your clotting times, your PTT, which is your prothrombin time, your partial prothrombin time, your PT, your INR, your fibrinogen. We will send that to check the patient clotting factors, because then you are thinking of bleeding, especially in this case with the patient being on HELLP syndrome. Also, depending on the gestation age, if the patient is below 35 weeks, provider tend to order steroid. This is just to help the baby lung maturity. It's normally celestone or betamethasone. Here in Jamaica, we used to use dexamethasone, but here we use celestone or betamethasone, whichever name you're familiar with. Jamaica is dexamethasone or decadron, whichever name you're familiar with. That's what we use. We also have this patient on continuous fetal monitoring because you want to know what is going on with baby as well. Doctor mentioned in her presentation the side rail safety. You don't want this patient to aspirate. You don't want this patient to injure herself during a seizure. So position is important. If this patient is still having a seizure, you want to position the patient on the side. This will prevent the patient from aspirating on her secretion. You want to have the side rails up, and not just up, but padded. In Jamaica, we didn't have the fancy pad that we have here. So what we do, we use blankets or sheet, we strap them to the side rail so the patient doesn't injure herself during a seizure on the rails, because the rails are hard. They can injure themselves as well on the rail. You want to have this patient on a cardiac monitor as well, because you want to know what the heart is doing, because take into consideration, we are giving magnesium, we are giving the labetalol, we are giving all these other medication. If the seizure is not resolving with magnesium, as the doctor says, you know, the doctor sometimes will order lorazepam to give to this patient, which we, the nurse, have to give. In Jamaica, they don't use lorazepam, it's diazepam. So it's the same practice, but the drug of choice may be different in the two different countries. Also, you're preparing this patient is NPO, which means nothing orally. They are not getting anything to eat, they're not getting anything to drink. Everything is by IV. When we are running the magnesium, it is piggyback onto lactated ringers. During the maintenance dose, we try to maintain, and again, it depends on the doctor's order, but most time it's 125 milliliters of fluid per hour. So this patient is maintained on the 2 grams of magnesium, which is running at 50, and then we have the lactated ringers running at 75 milligrams. That gives you a total of the 125 milliliters of fluid per hour that this patient is getting. And this is why it is important as well to monitor the urine output, because you want to make sure that this patient is putting out. We also monitor the neurological status while these patients are on magnesium. We check for the reflex. Is my patient reflex still present, or is it absent? Is it diminished? You know, because once this patient is on magnesium, you are monitoring for magnesium toxicity. You tell the patient what to look for. You know, so if your patient reflexes are diminished, you started out with a patient who had reflex, and you notice the patient is getting hyper reflex, it's like a 1+, or is it absent? The patient is telling you, nurse, I'm not feeling good. I feel like an elephant is pressing on my chest, or they have problems seeing, or the headache is getting worse. Then you know, you start to think, oh, and your respiration is important as well. Your respiration should be above 12. Is my patient having problem breathing? So you want to make sure that you are monitoring your neurological status of your patient, which takes in your conscious level, your reflexes. Is my patient having headache? You want to monitor your respiration. Is my patient breathing okay? You want to monitor your oxygen level. Is my patient saturating, perfusing okay? You want to monitor your urine output. Is my patient putting out urine okay? Am I getting that 30 milliliters an hour? And of course, you want to update your doctor along the way. Each step of the way, any change from the normal, you want to keep your doctor in the loop of what is going on with this patient. Also, with this patient, we tend to monitor the blood level of the magnesium. Some providers will say, no, don't monitor only if the patient is symptomatic. Standard routine, they would say, monitor the magnesium level every 6 hours. This patient in our scenario is in an acute phase, so the doctor might order for a repeat of the CBC, CMP, which is your complete blood count, your complete metabolic panel in a 4 hours after giving all that medication. You may want to see, is my patient deteriorating faster than expected? Also, depending on the stage, as I said, of gestation and the status of the mom. Is this patient stable enough? The doctor might order conservative management, wanting us to monitor this patient, keep this patient maybe for a 2 day just to get the steroids in. In this scenario, our patient was 32 weeks. This patient doctor would order the Celestone, the steroid, to help with the baby lung maturity, because before that 35, 34 period, the baby, this substance in the baby lungs that is needed so that the baby lungs can expand and the baby can breathe perfectly, known as surfactant, is not fully mature, especially in our scenario here, where this baby was 32 weeks. So that baby will need that additional support. If our mom is not stable enough for a vaginal delivery, then we as a nurse, we are preparing that patient for a C-section. And in our scenario, I believe our doctor will be preparing this patient for C-section once she's stable, bearing in mind that this patient sees at home and sees again in the hospital. So once the patient is stable, the doctor will try to expedite delivery. Able to deliver vaginally, and depends on the dilatation, is the same concept. They will try to expedite delivery, but most of our nursing function is focused on monitoring. We do a lot of monitoring because you want to identify things quickly. If you can identify what is going on quickly, then you can prevent the adverse from happening.
Thank
And
you.
I will stop here and
Yes.
let others jump in, and then I'll come back in if needs be.
Thank you very much for painting the picture of what the nurses in Jamaica and the nurses in America will do. So now we're going to go back to Dr. Miriam to tell us what happened to these patients, and then I will allow everybody to discuss in. So people who came in late, I will encourage you, put your name, your hospital, where you are, so we can, when we are going through the discussion, then I can call on you and at least know which hospital you're here, and then we can share more best practice. Dr. Miriam, you're next.
Okay, so the management offered to this patient loading dose magnesium sulfate. Here at Mwananyamala, we use both IV and IM for maintenance. So she was given IV 4 grams of 20% magnesium sulfate, and she was given IM 5 grams each buttock with lignocaine, and that continues 4 hourly for 24 hours. She was given tab methyl-dopa 500 milligram, TDS, tab nifedipine 20 milligram BD. Because the blood pressure was high, she was given IV hydralazine as a bolus, 10 milligram starch, and she was given IV fluid, that was 1.5 liters for 24 hours. The patient went for ultrasound, and it was confirmed that the baby was no longer alive. So the plan was to continue with vaginal delivery. So the plan was to augment the labor with misoprostol, where she was given 25 microgram, and she was given dexamethasone 10 milligram 6 hourly in 2 doses, then 6 milligram 6 hourly for HELP syndrome. So sample was taken for full blood picture, for blood grouping, for liver function test, for renal function test, urinalysis, and MRDT. And the patient was kept while monitoring vital signs, monitoring labor progress together with the urine output. So the investigation results: full blood picture, hemoglobin was 12 gram per deciliter, platelet was 61, she was blood group O positive, serum creatinine was 67, AST was 461, ALT was 241, urea was 3.8, MRDT was negative, and urine for protein was +4. So this is a vital trend since the patient was admitted and reviewed hourly, where we saw the blood pressure, how it was, the pulse, respiratory rate, temperature, SpO2, together with the RBG. So on admission, the blood pressure, okay, thank you. So the patient was managed and being monitored 2 hourly, 1 hourly, according to the vital trends portrayed there up. So 6 hours post-admission, the patient delivered by SVD, a male baby, that was fresh. However, she sustained perineal tear, first degree, that was repaired with estimated blood loss of 300 mils. She was given tab misoprostol and injection to an anxemic as prophylaxis for PPH. And post-delivery, on examination, she was alert, febrile, not pale, not jaundiced. Her blood pressure was 121/65. Her pulse rate was 105, respiratory rate was 20, and she was saturating 99 on room air, and her urine output was 500 mils. So then, 3 hours post-delivery, the patient succumbed another episode of convulsions. She had generalized tonic-clonic, associated with eye rolling, and tongue bite and mouth froth with loss of consciousness for about 1 minute. So vitals taken, she was dosed with secretions. Her blood pressure was 101/60, and by that time she was saturating 73 on room air. So suction was done. She was given another IV dose of magnesium sulfate, 2 grams. Then the plan was to continue with the maintenance because the patient was desaturating. By that time, she was on non-rebreather mask, 15 liters. So the plan was to intubate the patient. She was also given IV ceftriaxone and metronidazole because of secretions, so prevention of aspiration pneumonia.
Oh,
So as the preparation for intubation was done, the patient succumbed to cardiac arrest. So
oh,
CPR was done, however, it was not successful. So we lost the patient. That's the scenario. I would like to welcome the floor.
Thank you very much, Dr. Miriam, for sharing this scenario. As I said, even if we did everything we can, unfortunately, sometimes we end up with unfavorable outcome. The goal for learning from those situations is to make sure that we do the best we can. We learn the evidence-based practice. We share our knowledge. We share the scenario so we can learn from each other and be able to learn if there was any opportunity to do this thing again for another patient. We should be able to include what could be helpful and be able to provide the best care possible. So I am going to invite questions after I allow Dr. Emma to give discussion to that scenario and the outcome, and then go back to Sister Dolores for feedback from that outcome. And then I'm going to allow people from groups so then we can finish the discussion. Dr. Emma?
Yes, thank you. That was a very tragic end of the patient. I'm so sorry to hear that. I'm curious to hear, it sounded like they started magnesium sulfate, which is great. It wasn't so clear if after delivery, was the magnesium sulfate continued throughout? I think I heard you say that after the seizure, she got another magnesium sulfate. And my question is, was the magnesium sulfate continued, after delivery throughout?
Yes, the magnesium continued as she was on maintenance 4 hourly. So she was getting IM maintenance 4 hourly magnesium sulfate. So she was on magnesium sulfate.
Okay. And what was the dose of the magnesium sulfate that you were giving her?
We are giving her 5
5
grams.
grams every 4 hours?
Yeah, in alternate buttock.
Every 4 hours.
Yeah.
Okay. And I'm also curious about her creatinine function. I think the units that you use is a little bit different from what I'm used to. Was her kidney function normal or was it abnormal? Was her creatinine elevated or was it normal?
Her creatinine was normal, and urea was normal. So renal function test was normal.
Okay, got
Yeah.
you. Okay. Wow. So, maybe what I would potentially have done additionally, given that she was on the magnesium sulfate already and still had the seizure again, and then I think you said you gave her a 2 gram bolus at that point. Maybe it would have been a good time to check a level of the magnesium sulfate at that point, but also maybe would have given her a higher dosage of the bolus, because usually if somebody's on IV magnesium sulfate and then they still have a seizure, we're going to give them like a 6 gram even bolus additionally. So maybe if you transfer that to the IM, maybe a 10-gram bolus would have sufficed, especially considering that her kidney function was normal. So maybe she could take more magnesium sulfate instead of giving her the 2 gram bolus. So maybe that's one thing that could have been done differently. And also, I'm curious about the fetal heartbeat monitoring. It looks like I think you said it wasn't done. I'm curious why it wasn't done because that was a couple of hours that she was undergoing the labor, but I don't see that there was any fetal heartbeat monitoring. And I'm also curious how the baby did after the baby was born. Was the baby okay?
Okay. About the fetal heart rate, on arrival, the patient reported that she perceived the fetal kicks when she was born. But on arrival, when the doctor examined the abdomen, fetal heart rate were not heard. So they did an ultrasound and it confirmed no fetal heart rate.
Oh, okay. Those are demise. Okay.
So it
Got
was fresh after vaginal delivery. It was fresh.
Okay, so
So
the
when you
baby
say
did
the
not
fresh
make
means
it.
the demands.
Fresh stillbirth. Yes.
Okay.
Got you.
Okay.
Yeah.
Okay.
Um,
I'm-
I know Dr. Emma is still going. Hold on a second. There's a question from Kasanga Nkabu. Said, what is the role of the dexamethasone in the scenario, given that she said IUFD, so the baby was already gone? Why did you give the dexamethasone?
Okay, we gave dexamethasone because the patient had two diagnoses because of the HELP syndrome. So even the doses there, it's for HELP syndrome because dexamethasone for the baby helping lung maturation here in Tanzania, we normally give 6 milligram 12 hourly for 48 hours. But the dose given there, it was for HELP syndrome and it's not for the baby.
Okay. Thank you. Dr. Emma, sorry, go ahead. I didn't want to miss that question. Go ahead.
I think she's answered my questions. So I don't know. I was thinking about even delivering the baby at I think 32 weeks, and I was thinking, well, maybe this is the kind of patient that I would even have considered a cesarean section. But knowing that she had a fetal demise, I don't think it's worth it. Definitely, I think giving her some Pitocin to help her deliver that baby vaginally is the way to go. So I do like that that was thought about. So I think to me, I think it's just back to maybe just having given her a higher bolus of the magnesium sulfate when she did have the seizure, maybe checking the magnesium sulfate levels. If her creatinine was good, normal range, I think there was room to definitely give her even more of the magnesium sulfate, which hopefully maybe would have prevented reoccurrence of the seizures. Now, of course, you have to be aware of toxicity of magnesium sulfate, just like Dolores mentioned, because magnesium sulfate can also prevent somebody from breathing well and can even contribute to things like
Cardiac
respiratory
arrest.
failure. Absolutely. So, I don't know what her reflexes were. around that time. But if there was no signs of magnesium toxicity, I would definitely have given her a higher bolus than she got. But other than that, it sounds like you guys really did what you could. You gave her the magnesium sulfate, you induced her. Did she get Pitocin or did she just progress spontaneously?
No, we augmented her with misoprostol on admission. So
Misoprostol.
just, yeah, first dose of misoprostol, she had good progress throughout.
Got you. Yeah. And then just continuing the magnesium sulfate throughout and maybe just giving her the higher dosage of the bolus before when she had the reoccurrence. But that's really all I have to add at this point.
Sister Dolores.
Okay. Dr. Emma asked some of the questions that I was curious about in regards to this patient. Another thing I want to ask, and it's just because of several experiences I have with this happening. I don't remember if in the scenario she said this patient was having right upper quadrant pain. Because one of the things we have to remember with preeclampsia and eclampsia is that it can affect the liver, and that is why your LFTs are elevated. A lot of times these patients are bleeding into their liver capsule, and we may not know that that is happening. And this is because that come to my mind because recently I had a case like that. The patient was fine, having right upper quadrant pain, was on magnesium. The pain got worse. She did a C-section, and we were basically closing. And this patient, the doctor said, "What is the patient blood pressure?" The anesthesiologist respond, "It is low. She's having a hard time getting the blood pressure up." What I think sparked that doctor, this is case number one. I'm going to tell you about case number two. Case number one, the doctor was closing the fascia, but then he saw a little trickling coming through. And when she said that, the doctor did a longitudinal incision in the abdomen. The liver capsule ruptured. So that was why this patient was crashing in the OR on us. Another scenario which I had recently, not even a month ago, same similar situation, a ruptured liver capsule. Patient had C-section, came out fine. Blood pressures were dropping. We were giving albumin, thinking, and that because this patient was so swollen, because one of the things that preeclampsia or eclamptic patients present with sometimes is what we call edema, which is swelling. So this patient had generalized swelling. So they were thinking maybe because the albumin is low, maybe that's why the blood pressure not maintaining, because the blood loss in the OR was not a lot. So the patient was getting albumin, patient got blood transfusion, but the blood pressure kept falling. So they decide to the point that they thought the patient was having a seizure, but I think what happened is because the patient went into hypovolemic shock, the patient stopped respond, but they were thinking, oh, maybe she had a seizure because she's severe preeclamptic. However, when they did the ultrasound, the patient was bleeding inside. The abdomen
Wow.
was full with blood because of a ruptured liver capsule. So my thing in this, even though the patient was having a seizure and could have probably aspirated, bearing in mind that this patient is in ELF syndrome as well, I wanted to know, was this patient still having that right upper gastric pain, abdominal pain? Was there marked tenderness? Was the abdomen distended? Because this patient could have been bleeding and we didn't know. Also, as doctor mentioned, the magnesium, that was one of my concern. Was this patient still getting the magnesium? Because the doctor is normally ordered for us to keep that magnesium going for that 24 hours post-delivery or 24 hours post-seizure, the last seizure. And we monitor the magnesium level because, again, as she mentioned, the toxicity, magnesium toxicity is something that can cause the patient to go into a respiratory arrest or even cardiac failure. Also, with ELF syndrome, with the low platelet, this patient is even at higher risk for bleeding. This patient is at risk for what we call a DIC, so which is this disseminated coagulopathy. This patient may not be clotting as usual, and that is one of the reasons why our doctors here in the US order the clotting times at your PTT, your INR, your PT, because they are watching out for these things that may be happening. And that is why it's important for us as nurses to be very vigilant in monitoring patients like these, because sometimes we miss very little things that could help the patient.
Thank you, Dolores. That's a very good point about rupture of the liver capsule, because yes, we do know that that's a potential complication from preeclampsia. To be honest, I haven't experienced any of that in my 15 plus years in my career. I haven't ever had a patient who has had that, but I know it can happen. And I do believe that in that type of situation, you would probably need to call the general surgeons to come in and help with that. Yeah, maybe they would have to like do some type of surgery to control the bleeding. Yeah, but that's always a possibility. I wonder if an autopsy was done on this patient. I would imagine that I think everybody's assuming that it was the eclampsia that led her to the demise, maybe the aspiration. But I wonder if an autopsy was done that maybe even looked at her liver to see if it had been affected. Dr. Milam.
No. Autopsy was not done. We just confirmed the cause of death was aspiration, pneumonia due to eclampsia. That's all. It was not done. Yeah.
Dr. Sharon has the question. She said, why did the mother go home after diagnosis of preeclampsia? Definitely education is needed. I think
Okay.
Go ahead, Miriam.
Okay, as I said earlier, this patient came to our facility as a referral case. So she was living with her husband and she went to that hospital alone. Her husband was not around. So when they told her that she has to come to this facility, it is due to socioeconomic status. She reported that she had no money, so she had to wait for her husband to come back home. That's all. So when she was home there, she was brought here by neighbors because she had sudden fall at home. They explained features. And they were relating to conversions. So that was the reason, because socioeconomic status, she had no money, so she waited for her husband to come back from work so that he can brought her here.
Yeah, thank you. And that makes sense because the probably more the unfortunate thing for patient who is experiencing preeclampsia before they start getting that seizure is it's a very subtle feeling. The patient just feel weak, doesn't feel good, is swollen, doesn't sleep, doesn't eat. So when they said, okay, you need to go here, they're like, well, because there's no pain yet. They might take it as, well, let me just go home and do this and this first, and then or find it transportation. So they might not see as serious at that moment because they don't know what is happening in their body yet. And then, of course, definitely education is needed when whoever gave her the diagnosis, okay, this is serious. Like you literally could say, don't go home. Like you have to sometimes spell it out to the patient because they don't know. The same thing, somebody might be hypertensive and they don't know that, okay, this thing's going to fall on me. And since they don't feel good, I'm going to close my eyes and try and sleep. And then hopefully I'm going to wake up and do stuff. Then they might end up with a seizure, stroke, or whatever it is. So it's very good to have, to educate our patients. As soon as they're getting those diagnoses, just educate the risk and things that they need, the importance of referral. And sometimes, if possible, that referral could have been straight take them to the hospital versus allowing them to go. I know there's a lot of restriction and resources needed, but if you're coming from the lower acute care to go to the high acute care, hopefully there could have been a collaboration there to say this patient should go straight to the hospital. Don't send them to the regular car and stuff like that. But I mean, if those resources are there, then we could make that decision, but we don't know what happened before she arrived to a hospital. So, and I agree with Dr. Emma that you guys did as much as you could at that moment with everything that the resources you have to take care of these patients. Unfortunately, the outcome was not what we want, but it's something that we can learn from it and hopefully help the next patient who has the similar situation, then we can make it better for them. Sister Dolores, I see your hand.
Yeah, I was just gonna, and I know that's the situation in the third world countries like Jamaica, where these patients don't have, they may be living far away, don't have the means to get to the hospital. But here in the US, when the patient present to us with symptoms of preeclampsia, we normally, depending on how bad it is, but the first thing we do when they come in with those symptoms, we do what we call a pregnancy-induced hypertension, which is the whole name for gestational hypertension. We do a PIH workup, which takes in this, all that Dr. Emma had mentioned, your CBC, your CMP, your LFTs. We look at your protein creatinine ratio. You will hear the doctor mention it as a PCR. And also the doctor will order a 24-hour urine collection because they are looking at the protein how much protein is this patient spilling over a period of time. So most times than not, often than not, the patient is admitted for a 23-hour OBS just to monitor the blood pressure, monitor the protein, to get that protein creatinine 24-hour protein collected. So this patient most time in our setting would not be sent home, while depending on the stat, and if it's like from a clinic area that doesn't offer in-house OB here, then this patient in the US, they have the luxury of transporting this patient via ambulance. However, in countries like Jamaica and in Tanzania, you may not have, depends on where you live, it's either your bike, your bicycle, or your donkey. I remember when I used to practice as a midwife in Jamaica, because before I came to the US, I was a midwife. We used to do home delivery, and sometimes to get to those place to do those home delivery, we have to walk either miles, we either have to get a ride on somebody bike, or we have to take a ride on somebody donkey to get to that person. So it depends on where you are. It may be difficult to get this patient the care, and this is one of the drawback that these country faces. Is not that the nursing care or the doctor care is not there, it's just accessing it is a challenge. And I think maybe in this scenario, this is what happened. To access the care was a challenge for her. So by the time she get to us, the damage was done. They tried everything that they could, but this is some of the things that these countries, like, as I said, Jamaica, face accessing the care.
Thank you, Dolores, and also what has been said about how um, patients may not necessarily have the resources to present for the care that they need, and that definitely plays a big role in the outcomes also. So as much as doctors can do all they can do at the hospital when they finally show up, but a big part of the outcomes is also what did the patient do as far as like following up for care, presenting for care. That makes a huge difference. I mean, I was very struck by how even at 21 weeks of her pregnancy, when she had a pressure of 133/84, I mean, that wasn't high blood pressure yet, but it was pretty close to. And so this is the kind of patient that maybe I would tell her to come back in a week for follow-up for the prenatal care, so that if it looks like now it's getting up to 140/90, now you already have a diagnosis. And maybe this could have been picked up earlier, maybe when she was still like 22 weeks, for example, or even like 23 weeks. And so what if she had that diagnosis already established at 23 weeks? That would have made a whole outcome difference, because if maybe she knows she has preeclampsia at 23 weeks, so now we are potentially even considering inducing her earlier, because that's kind of early in the pregnancy, but also just educating her on the importance of the follow-up. Maybe this is the kind of patient who would have been hospitalized for a couple of days to determine if she had preeclampsia with severe features. And maybe if she had ruled in for preeclampsia with severe features, then she would have been kept at the hospital for the rest of the pregnancy until delivery, and maybe should have been on the magnesium sulfate all along, and maybe that would have prevented the initial seizure that happened, and then none of those things could have happened. So I think follow-up is very important. And if this patient, it looked like the follow-up was a little bit of a struggle for her, and there are things that she didn't have control over. I mean, if she doesn't have money to pay her fare to get to the hospital, we can't control that. So these are some of the social economic issues that affect the outcomes in the long run.
Thank you. Rehabura France said,
Just a question for Dr. Paul. In Jamaica, we have what we call community health aid, because we have to do a lot of home health. So these ladies tend to go with the midwives to visit these mothers, to follow up on these mothers, especially those who are delinquent in their care. So, and sometimes the community health aid would go to visit these ladies, not on their own, but most time is with the midwives. Just, do you guys have something like that in Tanzania, where you have maybe here, I think here in the US, they would maybe be your PCTs, which is your patient care assistants. What in Jamaica we have these ladies that work in the health department, we call them community health aides. They are the ones who will visit these mothers who we haven't seen come to the clinic. So we are keep a record of all these patients we see. Um, Before I left Jamaica, one of the things was that we used to do, because I've seen patients who have a eclamptic seizure with what we would call a normal blood pressure, 120/80. So normally what we used to do, before things changed to the 140/90 as being blood pressure, it used to be if your systolic is greater than 20 from your baseline. What was your baseline when you come in? Your diastolic is greater than 15 over what your baseline was. That was what we used to use to say, okay, this patient has gestational hypertension back in my days in Jamaica. But then things change, and it's now considered that you're hypertensive when your blood pressure is 140/90 or greater. But I believe that they still use, even though the standard has changed, I think in Jamaica they still use that to monitor that patient more closely. And so I'm just wondering if they have like what Jamaica have, community health aid, these ladies who will go out to visit these women at their homes to make sure that they are doing okay, even post-delivery, they are doing okay at home, baby's okay. We call that post-delivery phase domiciliary, because that's when we as midwife would go in with our little scale to weigh the babies and to make sure that mom is okay, getting the right nutrients and all of that.
Thank you.
Go ahead, Dr. Mary.
Okay, thank you. I would like to share. I think here in Tanzania, it's quite different. We don't have such practice. Here in Tanzania, we have dispensaries where mothers attend RCH clinics. Is from there all education nurses have been empowered, have been trained that they should provide health education to pregnant women about danger signs, everything about pregnancy. It's where they are provided education there. And on RCH visits, whenever they detect any problem or any abnormality, they normally talk to the pregnant woman and refer her to a facility where she will get better management or better care. So we don't have people who visit those moms at their homes doing what? No, it's on the RCH clinic. I swear every morning before starting services, they are given general health education, are educated on danger signs and everything. It's end up there. So once the mother is at home and face any difficulty, she just rushes at the nearby hospital, area, first management or aid given, and it's from there they can detect that this patient can go to a higher health facility for further management. So here in our country is how it's practiced. Thank you.
Thank you, Dr. Miriam. Comment from the audience, Kasanga Nkambu. He's saying another possible cause of death could be amniotic fluid embolism. Her labor was accelerated with misoprostol. My thoughts, they did best for Tanzania. No, we agree with you, Kasanga, that yes, for Tanzanian care for this patient, they did the best care possible for what they had. Yes, definitely. So we are discussing here to learn and be able to do better. When I say better, it doesn't mean that they did bad. No, better means to do more informed, more educated for what the possibility are available over there. If there's a different drugs that either US or Jamaica are using, then it can be introduced in Tanzania. Or if you have something that we've never heard, then we can learn and try to figure that part out. So this is just a learning opportunity for everybody. And then definitely they did a great job for what they itemized on the list. So definitely it's a good thing. So I'm gonna take your pointers. That could have been amniotic fluid embolism. Dr. Emma, what is your thought?
Yes, I did actually reply and said that absolutely amniotic fluid embolus could definitely be another potential cause of the mother's demise because it also just presents abruptly and all of a sudden mother is not doing well and she's not breathing and you try to intubate, but things are happening so quickly. So definitely that could always be another possibility. And so I did also say maybe if she had had an autopsy, maybe that could have determined too. Yeah, so that is always a possibility. It's definitely in the differential.
Okay,
Yes.
another comment. Thank you, Dr. Emma. Another comment is Rehabura Friends. He said, please may you share your experience on the use of calcium supplement and aspirin during pregnancy to prevent measures of preeclampsia. What is your thoughts?
Yes, aspirin has been shown to help decrease the risk of reoccurrence of preeclampsia, especially if a woman, for example, has a history of preeclampsia in a previous pregnancy that presented early. So, for example, if this particular patient, if she was to get pregnant again in the future, then I would definitely recommend for her to start taking baby aspirin. And it depends with who you want to follow. Some people say it's okay to take the baby aspirin from the very beginning, even before they conceive. And some people advocate for after the first trimester. So just taking a pill every day to prevent the reoccurrence of the preeclampsia, as well as anybody with other risk factors for preeclampsia, like if they have chronic hypertension, if they have kidney disease as a baseline, you may also want to encourage them to take the baby aspirin to prevent preeclampsia. If also they have things like diabetes, they could start baby aspirin to prevent preeclampsia. There are some factors which are considered mild risk factors for preeclampsia. So like a woman who's never had a child before, maybe this is the very first pregnancy, maybe if the woman has obesity, also if the woman is over like 35 years of age. So if they have two or more of those mild risk factors, you could also consider giving them aspirin from the get-go to prevent occurrence of preeclampsia. And the good news is that aspirin is widely available. Also, it's affordable. So I think that could potentially have also been used. I'm not familiar with calcium per se. I wonder if there's anybody else in the audience who's familiar with calcium use to decrease the risk of preeclampsia. Anybody familiar with calcium for prevention of preeclampsia? I'm not familiar with that.
I know we have a few doctors on the list there. Anybody has used calcium supplement to help with the patient's prevention of preeclampsia?
I think that's a doctor's preference, as I've seen most mothers who are in that risk period coming in that they're on magnesium supplement and calcium supplement along with the aspirin. So maybe that's a doctor's preference. Not sure. But the main thing I've seen used widely is the aspirin, but of late I've been seeing patients coming in when we ask what medication are you taking, they will tell you that they're on magnesium, they're on calcium, they're on apart from their prenatal vitamins, they're on a baby aspirin.
Okay, so that's a good question. We're going to investigate, and then hopefully in the future training we post it. And if we get that response before we send this recording of this training, then we can share that part. But that was a great question. Dr. Sharon is saying, I am in a study with the US with Dr. Brown Graham, where the patient is given, those are Dr. Brown Graham's is OBGYN, where the patient is given a home blood pressure monitor and measure her blood pressure twice a day to identify early elevation of blood pressure. Any elevation of greater than 10 milligrams of mercury is reported to the prenatal doctor. It is decreasing the rate of preeclampsia. So, I mean, there's a lot of school of thought. You can say people have different practice, different ideas. So something like that, I know it might be an issue for Tanzania to have extras of blood pressure monitors to give them out. But if people who are able to afford that, then that would be a great source of try to screen themselves and then go and talk to their primary doctor, definitely. That would be helpful. Any other comment? This is great. I know we overextend our time, but I see a lot of people are still here. That means that they want to learn something, so I don't want to cut short. But this has been a great information, great discussion. And Dr. Miriam, thank you very much for sharing and presenting this the scenario so we can learn. Dr. Emma, definitely always thank you for educating us and give us all those the theory behind it and the pathophysiology, definitely. And our very own Sister Dolores, sharing your experience, definitely has helped us to be able to put it into perspective, especially for nurses. We are visual, we want to see things, and so we can do it better. So thank you very much. Anybody has any comments, questions? And then I will let you guys go.
Add one more thing. I know we keep talking about magnesium sulfate. Magnesium sulfate, it's a great medication, but just keep in mind that some patients may not be the best candidate for magnesium sulfate. So for example, if the patient has a history of like heart block, heart disease, probably not a good patient for magnesium sulfate because that could make it actually worse for them. And that's why it's important, if you don't know if somebody has a history of heart block, when you are studying the magnesium sulfate, important for the nurse, especially who's at the bedside, to assess how the patient is doing, so that if there's any like major changes, if the patient is complaining, I have chest pain, can't breathe, obviously you want to like stop the magnesium sulfate because maybe this is one of those patients who cannot tolerate magnesium sulfate. If somebody has kidney issues, renal impairment, you will definitely have to consider the dosage that you may have to decrease the maintenance rate of the magnesium sulfate. And if somebody has something called myasthenia gravis, which is some type of autoimmune disease that affects the muscles of the person. These people who are chronically fatigued, they even have trouble with like opening their eyes, or they have trouble like walking even. That could be like some type of myasthenia gravis. And if you give them magnesium sulfate, it may actually make their symptoms worse. So very important as you're giving the magnesium sulfate to just assess how the patient is doing. If it looks like she cannot tolerate it, then you definitely want to consider other anti-seizure medications. So that's really all I have to say. I thank you, Dr. Harriet, for organizing this. This is so worthwhile, and it's wonderful to share the information across countries. And the world is becoming smaller, and this is great that we can all get together and discuss how best to take care of the women from all over the world, in the States, but also in Tanzania, in Jamaica. It's wonderful. So thank you, everybody.
Thank you very much, Sister Doris.
I just want to thank everyone for coming on to listen, and I've learned a lot. You never stop learning in the medical field, and just the teamwork. We have to continue work together as a team, to save lives. That's what we are here to help save lives, to do best practice, with whatever resources we have. It's not to beat on anyone to say you should have done this or you should have done that. It's a learning experience, what we could have done different. So if we have that situation happen again, we know where to direct our focus. As for me as a nurse, it helps me to be more vigilant where my patients are concerned. We have to monitor. A lot of time we take things for granted. They're in Tanzania, it may be like Jamaica, where it's cubicles. You can see your patient stand in the middle of the hallway and you see everybody. Here in the US, they are in rooms. You do not really get to see them. They don't have a neighbor beside them that can call you and say, hey, something is going on. So as nurses, we have to be very mindful of those little things and monitor the patients. Monitor the patients as if it's yourself. What would you want someone to do for you? You do it for that patient. Treat the patient as how you'd want someone to care for you. And again, thank you for having me. And thanks to both Dr. Emma and Dr. Paul. It's really an eye-opening situation with eclampsia. You see it so many times that sometimes they get sensitized to it, that you don't really think about what's happening on the other side. So, thank you, ladies, for your presentation, and thanks again to everyone who make it out to listen. Thanks, Dr. Gaboni, for having me, and congratulations on your award.
Thank you. Yeah, so to finalize this, the reason we do this training is because, as what Dr. Emma said, we want to learn from each other. We're not playing any blame to anybody. No, we just want to learn so next time we can do better. As I said, you never stop learning. Every time somebody asks the question, the aspirin, the calcium, we're going to find out to make sure that we are informed. And then the best part, hopefully, we get out of this is the education for our patient. They don't know what we know. So if they don't know, when we're giving them this diagnosis, we're giving them instruction, we have to go further. We have to be able to say, okay, yes, preeclampsia, A, B, C, D. You're going to worry about this. You might not feel like this one, but this is serious. If we give them and educate as much, hopefully she could have sought help earlier. Hopefully we could have changed the outcome. We don't know, but we're going to try to change it for the next outcome. So if we are able to do that, we are all learning. I appreciate everybody coming in and people who are coming as an audience, all learners. We want to hear from you. We're going to record, we've been recording this meeting. We're going to send it out. Everybody who attended is going to get a certificate for attendance, for being here. And then we want to be able to hear from you. Usually you're going to have the email for the organization. Send your questions, send your comments. If you have a comment, question specific for the presenters, I can share with Dr. Emma or Sister Dolores or Dr. Paul. that what you want to hear. And if there's so many questions we get, then we're going to get another second session of preeclampsia or eclampsia or whatever the questions that you want, or any obstetric emergency. We didn't even go to postpartum hemorrhage because of preeclampsia. So all those things, we could have continued that part. If there's an issue is happening on your hospital, let us know so we can try and share our best practices and we can learn from you guys. So with all that, thank you for coming, and we post the video as soon as it's ready. Okay.
Okay.
Bye.
Thank
Thank you,
you.
everybody.
Bye.
Bye.
All right.
Thank you.